Thank you, everybody, for joining us for Grand Rounds today. We have a wonderful speaker, Dr. Yousaf Ali, who's a professor in the Department of Medicine in the Division of Rheumatology and the division chief over at Morningside and West. He's an expert in gout and rheumatoid arthritis and lots of other key topics in rheumatology. Delighted to have him today talking about updates in rheumatoid arthritis. Dr. Ali.
Thanks, Matt. Just want to make sure you can hear me okay before okay, good. So can you see my screen?
No, I think you need to reshare. Sorry,
Hang on a second. How's that?
Perfect.
There we go.
Yep, perfect. And then just go into presenter mode. Yep.
Okay, great. Well, Matt and Ryan and others, thanks for the invite. I'm happy to be here virtually. So I've been told I have 50 minutes, so I'll do my best to stay on time. And I'll try and use the chat box as much as possible. So feel free to enter stuff into that. So the goal of this next 50 minutes is talk about rheumatoid arthritis, recognize patterns of RA, appreciate a little bit about the diagnostic criteria, what blood test to order if you're suspecting someone with rheumatoid, and then talk a bit about treat to target goals. So we're really, like the IBD folks, trying to get patients in complete remission so they have no deforming disease. So I'll start with a case. This is a patient I saw several years ago now, but a 66-year-old African-American female who had 4 hours of stiffness in the morning for about 8 months. So she would wake up, feel like an old lady, as if she needed to be oiled. She had myalgias, fatigue, she had hand pain, and she had difficulty arising from a seated position. It took her about an hour to get dressed. She couldn't use her utensils. And she went to see her primary care doctor, and the PCP ordered some bloods and x-rays, and the labs showed a normocytic anemia. Hemoglobin was 10.5. SED rate, we'll agree, is very elevated at 122, and the renal function was normal. And the wrists did show wrist swelling, left greater than right. So the question is, what investigations would you do? I don't know if do we have a chat box that we can and open it up to people? What blood tests would you order, if anything, or what tests would people like to order at this point? I actually can't see the chat box, but Matt, can you see it?
I'm keeping an eye on it.
Okay. Feel free to read out what people have said.
Sure.
Like, would you do any tests in this person other than that have been done?
So ESR CRP.
Yeah.
Wrist X-ray, ANA, rheumatoid factor.
Okay. Good. Okay, so I'm going to keep going. So the wrist X-ray showed bilateral carpometacarpal osteoarthritis. This was actually when I was in practice up in Brown in Providence, and so they did a line test in almost everyone with arthralgias and fatigue. CPK, because the patient had difficulty getting up out of a chair, so you'd think about myositis. Uric acid, which was probably not necessary, immunoelectrophoresis, and a rheumatoid factor and ANA were both negative. So this is someone who's got stiffness, she's got pain, she's got wrist swelling, and she's got negative serology. So rheumatoid and ANA are negative. And a presumptive diagnosis of PMR was made on the basis of a SED rate of 122. Patient was put on prednisone 60 milligrams daily, which, as we all know, if you give 60 of prednisone to anyone, it makes everything better, including sinusitis, including lymphoma, etc. But as you'd predict, as the steroid was tapered, the symptoms recurred. Now, 8 months later, the patient finally ended up in rheumatology clinic. And this is an important point because the patient had symptoms for 8 months, was treated with prednisone for 8 months, and then finally 16 months later showed up in the rheum clinic. And I'm just seeing how I could forward my slides here. Okay. So this is what the patient's hands look like. And I think we can appreciate that there's significant left wrist swelling. But if you look carefully, and hopefully you'll agree with me on this, there's swelling over the MCP joints here. There's loss of definition of the knuckles. And if you look at the third PIP joint bilaterally, hopefully you'll agree that there's swelling of the PIP joint. And so when you squeeze that joint, and people can feel free to do this on themselves, if you squeeze your third PIP joint or any of your PIP joints, you can actually squeeze very hard and it should not hurt you in any way. So this person has swelling of the wrist. Yep, Matt, no pain, right? I can see you. Okay, good. So the patient has swelling of the left wrist, loss of definition over the MCPs, the PIPs are swollen. So this person has a symmetrical small joint arthritis. And what I did is I did some x-rays of the hands, wrists, and feet. And here you can see that there was a big erosion at the PIP joint. So this is what's called a marginal erosion or a rat bite erosion. And that's quite consistent with synovial proliferation eating into the joint. So we made a diagnosis of rheumatoid arthritis on the basis of symmetry, small joint arthropathy, elevated inflammatory markers, but negative rheumatoid factor, negative ANA. I put the patient on methotrexate, and in 3 months, the patient was off prednisone. So this is an instructive case, and the question is, why the diagnostic confusion? And there are a few points here. Number one, the patient had primarily left wrist swelling, and they just did a wrist x-ray as opposed to hands, wrists, and feet. And if they did hands bilateral, they would have picked up that PIP erosion. Second is that they were led astray by the radiologist, because if you look at x-rays of people's hands, almost everyone has osteoarthritis at the base of the thumb. And thirdly, they did not think about seronegative rheumatoid, which affects about 20% of patients. So just a little bit about rheumatoid. So this is a very common disorder. I'm sure everyone's seen this. Affects about 1 in 100 people. That's worldwide. In certain ethnic groups, so Native Americans, certain Indian tribes like Pima Indians, it's as high as 5 to 6% of the tribes people have rheumatoid. So very high. In certain parts of West Africa, like the Kalahari and Kenya, it's as low as 0.6%. Like many autoimmune diseases, rheumatoid affects females to male in a ratio of 3 to 1. And it's associated with certain HLA haplotypes, the DR4 and DRB10404 haplotypes. So there's certain genetic predispositions to rheumatoid. The genes are not the whole picture, obviously, because even if you look at identical twins, concordant studies, only about 12 to 15% of the other twin has rheumatoid if one twin has RA. And that probably brings up other factors such as environmental risk factors, such as smoking. If you smoke a pack per day for 3 decades, that almost doubles your risk of rheumatoid. We've seen in the World Trade Center group that silicon dust inhalation can increase your risk of most autoimmune diseases, but certainly rheumatoid. And obesity, we know that adipocytes are pro-inflammatory and increases the hazard ratios of rheumatoid arthritis. Also, certain infections can predispose to RA. We know that changes in the microbiome, Prevotella, copri particularly, which is also found in the mouth and in the lungs, can predispose to RA. And there are some patients who've had parvovirus or even EBV that actually will then go on to develop rheumatoid. Just trying to advance my slides here. Okay. So these are 1987 criteria for the diagnosis of rheumatoid arthritis. And I'm putting these up deliberately, although I understand that they're 3 decades old, because they're fairly helpful. So if you have someone with joint pain sitting in front of you in clinic, and you're trying to ask yourself, do they have RA? Think about these criteria. So morning stiffness lasting at least an hour, and it can be, to be honest, 40 minutes, it can be 30 minutes, it can be all day. Soft tissue swelling in at least 3 joints simultaneously. So if someone just comes in with one swollen knee or podagra, that clearly doesn't count. The joints affected classically involve the wrist, MCP, or PIP joint. There's classically symmetry. You may see rheumatoid nodules, you may see a positive rheumatoid factor, and you may see erosions on X-ray. So they say that you need 4 out of 7 criteria to have RA. Now, they are very flawed, these criteria, and I'll show you why. And they are probably more suited for diagnosis of more advanced disease. So that by the time you see rheumatoid nodules, there's quite advanced disease. By the time you see erosions on the X-ray, that means the disease has progressed. So if you look at this patient, this is someone I saw fairly recently who had subacute inflammation for only 4 weeks. She had a rheumatoid factor of greater than 800, a CCP antibody of greater than 250, and a SED rate of 60, and her X-rays are normal. So according to 1987 criteria, she does not meet criteria for RA, but if you can see here, her PIP is swollen. There's the lack of symmetry, but she's serologically off the chart, so she probably does have rheumatoid. And these criteria have been updated. So these are the new criteria that were approved in 2010. And they look at different domains, and you get different points per different domain. So you get points for small joint arthropathy. So she gets 2 points because she has 1 PAP. You get domain for points for serology. So she has a positive CCP, high titer. She gets 3 points for that. Duration of synovitis, it's less than 6 weeks. So she gets 0 for that. And positive or elevated SED rate in CRP, she gets 1 point. So if you have more than 6 points, that's definite RA. So she has 3, 4, 5, 6. So she has rheumatoid arthritis. And we would treat based on that. So just a few words about anti-CCP antibodies. So these are anti-cyclic citrullinated peptide antibodies, highly specific for rheumatoid arthritis. And these antibodies are present, if you look at military recruits, they're present before the onset of rheumatoid arthritis, up to a decade in some patients. And it's a helpful test because rheumatoid factor lacks the specificity, and I'll show you in my next slide about that, whereas CCP is highly specific. So if you think about patients with hepatitis C, many of those patients have positive rheumatoid factor and they have a negative CCP antibody, and they have arthralgia. So if you're trying to tease out, is it hep C related arthralgia or is it rheumatoid arthritis, you can get a CCP antibody. So I think we talked about this. The other thing with CCP antibody is that it predicts which patients will have persistent erosive disease. And so it has a prognostic indication as well. This is data which was published several years ago, which looks at patients who are CCP positive versus CCP negative. And in the black dots are CCP positive, and across the board they have, compared to the CCP negative patients, they have higher SED rates, they have higher disease activity scores, higher CRPs, and higher disease burden in general. So the presence of a CCP antibody indicates the patient has probably more severe disease and you should be more aggressive with them. This is a pooled meta-analysis looking at the sensitivity and specificity of anti-CCP versus rheumatoid factor. And the key take-home points of this slide are that the anti-CCP antibody is 95% specific for RA, whereas rheumatoid factor is only 85% specific. So you have about a 15% false positive rate for positive rheumatoid factor. This slide shows what else will give you a positive rheumatoid factor. So it goes up with healthy individuals, goes up with the elderly, goes up with endocarditis. So in patients with bacterial endocarditis, they have a positive rheumatoid factor. When you treat them, the rheumatoid factor disappears. Bacteria in the mouth, like we mentioned, periodontal disease, Lyme disease, hepatitis C, parvo, rubella, and so on. So don't be, you can misdiagnose rheumatoid arthritis if the patient has any one of these common disorders. So think about, is it a symmetrical small joint arthropathy? Could it be a false positive rheumatoid factor? And do they have a positive CCP antibody? Now, rheumatoid is a very different beast than osteoarthritis because I'm sure many folks, I'm assuming most people are internists, but are a mixture, but when you have patients in front of you and you say that they have rheumatoid arthritis or diabetes or hypertension, we have this battle that ensues about how I don't want to take medications. And I'm sure many people can relate to that. But the problem with RA is it tends to be a progressive disease. So if you look at patients in our rheumatology clinics, and if they come in and they've had 2 decades of rheumatoid arthritis, about 80% of them are disabled and 20% have severe disability. The life expectancy of these patients is reduced, and we know that there's accelerated coronary inflammation, and we're doing some research on that as well. So these are patients that we need to be relatively aggressive about treating to prevent deformity. this is a slide that was done by a Dutch group, Van der Heide, and what she looked at was x-rays of hands, wrists, and feet in early rheumatoid arthritis. And interestingly, what she found is that irrespective of symptoms, that there were more erosions in the MTP in the feet than the hands, irrespective if you had no foot symptoms. So if you are suspecting rheumatoid arthritis, you should get bilateral hand, wrist, and feet x-rays. And you may have normal x-rays in the hands, but you may see erosions at the MTP. So this is a very important tip. The other thing is, again, if your pretest probability is high, remember, we're only as good as the tools that we use. So an x-ray, you have to have 40% of the joint damage before you see anything. And here you can see a normal x-ray in a rheumatoid, but an MRI that shows an erosion of the scaphoid. So if your pretest probability is high, go looking for the erosion. So you can get an ultrasound, you can get an MRI. It affects quality of life, similar to many of our diseases. So 80% of patients are tired, 40% have severe fatigue. So if you think, when people return to their clinics after this lecture, and you ask patients about fatigue, everyone will say, yes, I'm tired. But I could probably ask the same question to the residents, right? And they will say, yes, I'm fatigued. But if someone has unexplained fatigue, ask them about joint, squeeze their MTPs. Could this be rheumatoid arthritis? These patients have loss of productivity, and the annual lifetime earnings loss is about 50%. This is an interesting slide that looks at the relationship between inflammation and disability. And it is as you would predict early on. So if you have, like, say, 30 swollen joints, you can't make a fist, you can't go to work. And it's closely linked together. But as the disease progresses over the years, the flare-ups become milder and milder, but there becomes a separation between the inflammation and the disability. So the disability increases, and you can sort of draw this line through this. So this is what we're really trying to prevent. The American College of Rheumatology has recommendations. So we're really trying to be aggressive about this. Most RA is actually seen early on by the primary care physician. So we have this critical window of opportunity where we're trying to prevent progression or onset of erosive disease. So goals of RA management: to prevent and control joint damage, prevent loss of function, eliminate pain and swelling, and aim for complete remission. Now, this is a hot topic, of course, money, cost allocation. And it's an old slide, actually, but it's quite relevant because it looks back at what's the cost of these rheumatoid patients. And in these days, when this slide was made in early 2000s, late 1999, most of the cost was actually from joint replacement. So hospital admissions, 52% of the cost looking after rheumatoid. Medications was 26%. Here you have the lowly rheumatology physician is only 9%, and the lab test 5%, miscellaneous 8%. This slide has probably changed so that medication is taking a big chunk of this now with the biologics. And if you talk to the hand surgeons, we have a good group of hand surgeons at Sinai. The senior hand surgeons will complain that we don't send them enough rheumatoid hands. So the junior physicians, junior surgeons don't actually know how to do MCP arthroplasties because of the biologics. They don't see that type of advanced disease. So it's a really success for us and for the patients. This slide is a bit busy, so I apologize. But this is about pathogenesis. So if why does rheumatoid happen? You have risk and susceptibility factors. So you have a genetically predisposed host who may be MHC class 2, HLA-DRB positive, who then is exposed to the microbiome, Prevotella or bacteria in the mouth or the gut. Those bacteria have enzymes that cause citrullination of amino acids. So you get citrullination of arginine to citrulline. And then that new amino acid is a new protein to the immune system. That's called a neopeptide. Those neopeptides are then taken up by antigen-presenting cells and then presented to T cells by a T cell receptor in the presence of an MHC class 2 molecule. You get activation of T cells, and then you get the production of these pro-inflammatory cytokines. You get synovial proliferation. You get rank ligand activation, so you get cartilage destruction. And then you get autoantibodies, including rheumatoid factor, IL-6, and then activation of fibroblasts as well. So this is where it all starts up here. This is an interesting study that, and this has been repeated since, but this is a study that looked at rheumatoid patients, 57 healthy rheumatoid versus 52 healthy controls. And they looked at their periodontal health. And basically what they found was that they did dental exams, and they found that the odds ratio of periodontitis in rheumatoid patients was 8.05 compared to controls. So the thinking is that it may be that oral bacteria may be predisposing to, there may be the source of this arthritogenic peptide. So I always look at my patients' mouths. I have them see the dentist, because that's a potential source of antigen that can drive the immune system. And this has actually been known way back. This is Lord Chesterfield in the 1800s, where he described gout as the distemper of a gentleman, whereas rheumatism is the distemper of a hackney coachman. Those of you who know London will know that Hackney is sort of a dodgy part of East London. And I guess these coachmen had rheumatism because they were also renowned for having very poor dentition. So in rheumatoid, you have this cytokine disequilibrium. You've got too much pro-inflammatory cytokines such as TNF, IL-1, and IL-6, and not enough anti-inflammatory cytokines. Just looking at TNF, tumor necrosis factor, TNF activates the synovium, activates osteoclast, synoviocytes, and chondrocytes. So you get bone resorption, which result in erosions. You get joint inflammation, which results in this pain and joint swelling, and you get cartilage degradation, which results in joint space narrowing. So clearly it's a very attractive target. If you can block TNF, you can reduce all of these things. So this is a clinical spectrum of rheumatoid, and this is early rheumatoid on the left. This is sort of mild to moderate rheumatoid, and this is what we consider more advanced rheumatoid. So if this person came to see you in your clinic and they had minimal stiffness but some deformity, the question is, how aggressive would you be with these patients? So I don't know if Ryan, if you're still on the call here, but question in the chat box, would you refer this patient if you saw this patient? Would you treat the patient? You know, how aggressive would you be with someone with more advanced disease, for instance? I'll give you a few minutes. So thinking in your busy clinic, you see this patient and they've already got deformity, they've already got nodules. Ryan, I'm not seeing anything, so shall I just keep going?
Yeah, nothing in the chat so far if you want to just keep going.
I'm going to keep going, that's fine.
Okay.
So the reason I asked that question is because, so you think, you know, patients can not get worse, but this is a person that I saw recently who actually was diagnosed with rheumatoid at age 60, declined, I'm not sure why it's moving around, declined treatment, and then was lost to follow-up. I saw her at age 80, and look at the deformity that you're seeing here. I mean, it's really advanced. So this is someone that cannot function in any way, cannot look after themselves, 0 ADLs. So again, it can be a very aggressive disease. So I think probably those patients probably should see a rheumatologist at least once. I'm going to just go through, I know it's lunchtime, but I'm going to just go through some images of rheumatoid. So this is someone who's got rheumatoid nodules on the extensor aspect of their wrist. You can see this. And what happens is that the pannus and the nodules eat into the extensor tendons and they get a rupture of the extensor tendon mechanism. This is someone who has a classic swan neck deformities with deformity that you see in rheumatoid, and that can be can affect their grip function. This is someone who has loss of the thenar eminence here, and so they have recurrent carpal tunnel syndrome, and the patient will go from sometimes surgeon to surgeon, they get their carpal tunnel decompressed, but what's really they're missing is that the patient has pannus and erosions or synovitis in the wrist joint. So what the patient needs is not decompressive surgery, but they need rheumatoid arthritis treatment to decrease the wrist swelling. So if you're seeing someone with recurrent carpal tunnel, ask yourself, could it be because there's RA in the wrist? This is arthritis mutilans. So this is someone who has severe disease where the joints have just been eaten away. You see this also in psoriatic arthritis. And again, this is similar to the patient I showed you with a severe deformity of the hand. And the analogy I'd give you in this would be someone with diastolic hypertension who then comes in with a massive stroke. So this is almost too late. There's nothing that we can do except salvage therapy in this patient. So this is what we're trying to prevent. For those of you doing boards, don't forget that rheumatoid patients can get effusions anywhere. So if you have a big knee effusion, you get a Baker's cyst, and sometimes that can rupture, and the fluid dissects down the fascial planes. They get this swelling of the leg, and it looks just like a DVT. You have to rule them out for a DVT, but this is a ruptured popliteal cyst, and they may show this in your medicine boards. Sometimes you get a clue, you get a crescent sign where there's bleeding down the fascial planes, and that can be the clue that this is a rheumatoid ruptured popliteal cyst. In RA, it's not just the hand, so don't forget to look at the feet. This person has what we call metatarsalgia, so it's like walking on marbles. So there's MTP inflammation. So not only are we going to address the systemic inflammation, but we're also going to put in sponge, give them heel inserts, send them to podiatry. They can actually create a special pad where they walk on the sponge as opposed to actually the MTPs. This is someone with scleromalacia of the eye, and this is again because cytokines are systemic, so TNF and IL-1 and IL-6 are in the circulation floating around, and this is going to the sclera, causing local inflammation. And it's important to treat because if you don't, you can get what's called scleromalacia perforans, where the eyeball actually perforates, and this would be one of the few instances where I would use sort of pulse steroids and Cytoxan in a rheumatoid patient. Fortunately, this is a rare finding. We don't see this very often. This is rheumatoid vasculitis that you sometimes see, and I used to see this more in the UK, but here, because there's more access to healthcare, at least in well, I'm going to show you that. That's debatable. Earlier access, hopefully, you can pick this up. So we don't see this too much anymore. The other thing that you may see on your boards, and important to know, is C1, C2 subluxation. So you can get pannus at the atlantoaxial joint, and that causes erosion and laxity to forward flexion and extension. And this is important. You should do flexion extension films before you send someone perioperatively for intubation, because there are reports of people getting intubated and then they wake up paralyzed. How about the lung? Rheumatoid affects pretty much almost every system, but the lung, you can get exudative pleural effusions with a low glucose. You can get bronchiectasis, which is certainly increased. You can see BOOP. I've seen BOOP, I've seen BOO, and I've seen OOP. Some people have speech abnormalities, so you can get cricoretinoid arthritis, interstitial lung disease, interstitial pneumonitis, pulmonary hemorrhage, and vasculitis in the lung, I'd say, is very uncommon in rheumatoid, much more common in lupus. You can get respiratory muscle weakness. And a recent paper just came out looking at methotrexate and does it exacerbate interstitial lung disease and lung fibrosis. And there's a nice prospective study done over, I think, a 15, 20-year period in the UK, which actually showed that methotrexate probably does not accelerate pulmonary fibrosis. And in fact, patients on MTX had a survival benefit. This slide is a bit busy, but don't forget, so you can also get secondary Sjogren syndrome. You can get hematologic abnormalities such as Felty syndrome, which is splenomegaly, leukopenia, and rheumatoid arthritis. You can get a membranous nephropathy, and in chronic rheumatoid, you can get secondary amyloid in the kidneys. And then don't forget, with chronic steroids and high levels of TNF, you can get osteoporosis as well. Rheumatoid nodules, purpura, and pyoderma gangrenosum I classically think with IBD, but I guess it's been reported in RA as well. The nodules can be very troublesome. They tend to occur over the digital pulps and the elbows. And you can certainly resect them. You can send them for hand surgery for resection, but sometimes they come back. There are also reports, paradoxically, that methotrexate can make that worse. I'm not sure why. The nodules have been reported everywhere, including the brain, the pericardium, but they classically occur over extensor tendons as well. Okay, so I'm going to talk a bit about treatment, and where do we go with this disease? And so right at the bottom of this is the therapeutic pyramid. So the first is obviously to make the correct diagnosis. We start with NSAIDs. I think for primary care docs, if you want to use low-dose bridge prednisone, I think it's reasonable. So if your pretest probability for RA is high and you're convinced the patient has RA and they have a positive CCP, and you call rheumatology and it's a 3 to 4 month wait to see rheumatology, if you want to give 5 to 10 of prednisone, I think that's reasonable. I also think it's fine to give DMARDs such as Plaquenil. If you're brave, you can give methotrexate. So we usually step up to either methotrexate or triple therapy. And then after that fails, then we go to anti-TNF or JAK inhibitors, and there's an IL-6 inhibitor, a couple of IL-6 inhibitors, and even rituximab. The new kid on the block, or the new kids on the block, are the oral JAK inhibitors, and I'll talk a bit more about that. Now, I've just told you that it takes a while for things to evolve, and so there are some people that say, well, why are we waiting to treat the patients aggressively if erosions occur in the first 3 months? Maybe we should be more aggressive and turn it upside down. And this is a little controversial, but we're trying to get earlier access of our rheumatoid patients into rheumatology so we can prevent the deformity I showed you. This is a slide that's both optimistic and pessimistic, but if you look at, this is referral patterns, and look at pre-1986, this is the time of the first rheumatoid symptom onset to rheumatology referral. So before 1986, it would take 20 months to get in to see a rheumatologist. And before 1986, it would take 100 months, so almost 8 years before they actually even started a DMARD. And in 1997, it was down to 3 months to get in to see rheumatology, and now less than 2 months to start a DMARD once you see a rheumatologist. So we're making good strides, but we can definitely do better. This was a study that came out a few years ago looking at, this was a questionnaire looking at attitudes for managing rheumatoid arthritis. And for the residents who are interested in doing surveys, just look at the amount of work involved. So they did 5,000 invitations, and they got less than 5% response rate. So 275 completed the survey. And the question they were asking is, how comfortable do you feel starting a DMARD? And so do you feel very comfortable, somewhat comfortable, very uncomfortable? And only 9% of primary care docs felt comfortable starting a DMARD. And that includes hydroxychloroquine, that's Plaquenil. And 19% felt very uncomfortable, 42% felt somewhat uncomfortable. People felt a bit more comfortable continuing a DMARD if it's already been started. And I think that's probably what we see in New York as well. This is a slide that I always try and, when I'm trying to recruit and increase our division size. I know down at Union Square, you've had the same issues, but this is number of people per rheumatologist. And so in New York and in the Northeast, it's about 30,000 people in New York, one rheumatologist per 30,000 people. In the Northeast area, there's currently one per 42,000. If you look at the Southeast and the Northwest, there's one rheumatologist per 70,000 people. But if you look at the projections in the next decade, by 2025, the Southeast is projected to have 101 rheumatologists for 137,000 people. And same in the Northwest, one rheumatologist for almost 200,000 people. So big shortage of rheumatologists. So for residents interested in our specialty, I think we have great potential. There's going to be a ton of jobs out there. So apply for fellowship, now's the time. Okay, so let's talk about changes in treatment of RA over the past 3 decades. So in 1980s, we would use gold. I just saw a patient in clinic who was on gold at one point. We'd use Cytoxan, we'd use penicillamine, which we never use. Now we're using triple therapy, methotrexate, Plaquenil, sulfasalazine. We use some leflunomide, Ereva. We're using a lot more biologic. These are anti-TNF drugs, abatacept, which is a co-stimulatory blockade, rituximab, tocilizumab is anti-IL-6, and tofacitinib, UPA, and baricitinib, these are JAK inhibitors, and they're pills. So you are seeing someone with rheumatoid arthritis, they're in your clinic. How do you measure disease activity? So obviously clinical signs and symptoms. So are you stiff? Are you achy? Do you have fatigue? Do your hands hurt? How bad is the pain? 0 to 10. We measure acute phase reactants, SED rate, CRP, and we should be doing annual x-rays. So if you're following rheumatoid patients in your office and they don't go back and see their rheumatologist, for whatever reason, at least try and get annual x-rays to look for progression of disease. And if you're seeing more and more erosions, that's a harbinger of accelerated morbidity, mortality, and also coronary disease as well. So those are patients that you can maybe push to get them back in with their specialist. And it can be very meaningful if you show the patient their x-ray and you show them 3 new erosions, that can be very motivating. Now, this is the problem with traditional DMARDs. So drugs like methotrexate and sulfasalazine, that we can only get 1/3 of these patients in complete remission. So that's swollen joint count of 0, tender joint count of 0, and CRP of less than 1. And most patients, like 2/3, are in either partial remission or no remission at all. So this is a problem. And this is part of the issue. This is a slide looking at the probability of continuing DMARD therapy. So if you look at a drug like gold or even hydroxychloroquine, 5 years out, if we just look at hydroxychloroquine, which people are more familiar with now with COVID, only 20 to 25% of patients 5 years later with RA actually remain on the drug. And that's because of lack of efficacy. The reason methotrexate is the gold standard anchor drug is because sort of 60 to 70% of patients 5 years out remain on the drug. And that's probably because it's well tolerated, has relatively predictable side effects, and it's efficacious. I'm going to zoom through some of this, but this is just a slide looking at cytokines and how we neutralize them. There's basically 2 types of cytokines. One are monoclonal antibodies like infliximab, Remicade, and the other are soluble decoy receptors like etanercept. These are characteristics of these biologics. So these are drugs I'm sure you've seen, and if you watch TV between 6 and 9 p.m., you'll get bombarded with direct-to-consumer ads of Enbrel and Humira, and happy people running across fields and that kind of thing. And I won't bore you with too much of this, but Enbrel's once a week. It's a anti-TNF soluble decoy receptor blocker. Infliximab that the IBD folks use as well. This is a chimeric monoclonal antibody that's given classically every 2 months. You can get neutralizing antibodies. Humira every 2 weeks, anti-TNF. Anakinra or Kineret is actually FDA approved for RA, but doesn't work. It works better for things like Still's disease, gout, and familial Mediterranean fever. Orencia or abatacept is a co-stimulatory blockade. It's given IV or sub-Q. And then Rituxan, I like, particularly in the non-compliant patients or folks you think cannot take medications very well, because you can give 2 infusions of rituximab once a year, and that's enough. Okay. And this is from the early data when this was presented by Mike Weinblatt when biologics first came out. And this is a comparison of etanercept, Enbrel, to methotrexate. And methotrexate is in the white and Enbrel is in the yellow. And you can see these are ACR 20, 50, and 70 responses. So think of 20%, 50%, and 70% improvement. And you can see that the biologic is far, far superior in terms of inducing remission and reducing decreasing pain and inflammation. Now, this is a slide of Humira looking at ACR response. So this is, again, response at 6 months. And this is ACR 20. So think 20% improvement, 50% improvement, 70% improvement. And so the blue is Humira plus methotrexate. Actually, let's focus on the purple. So that's 40 milligrams plus methotrexate. So 60% response, 50%, and 20% response compared to methotrexate in the white, so it's a lot less. So the biologics are far more efficacious. Now, this is my one slide that I do have to confess was given to me by the pharmaceutical industry, the makers of Humira AbbVie. And I put this slide up as a teaching point because Those of you, particularly for the residents, when they go out and practice, you're going to be given a lot of glossy paper that the reps will show you. And what this shows is this is radiographic progression. So the higher the number on the y-axis, the more X-ray damage there is. So this is methotrexate alone. So there's more damage, 10.4, that's methotrexate. And down here, this is methotrexate plus Humira. There's much less damage, 1.9. So if you take the combination of Humira plus methotrexate, radiographically, you're going to have less progression of disease. Now, this is true. However, I will say that what they don't show you and what the pharma companies are very good at is cherry picking their data. This vertical y-axis actually goes up to 244. So if we actually tabulated it, these slides, these graphs would be, these lines would be a lot closer together. So this is just more for a teaching point for the residents. So when, hopefully you guys don't have too much exposure to the reps, but at some point you will. So critically evaluate the data that they show you. Anyway, so ACR guidelines, and I'll zoom through this. So we're looking at a treat to target strategy. We want remission. We start with methotrexate, monotherapy, and then you can add different agents. So you can add sulfasalazine, you can add Plaquenil, and if the patient is still active, you can add a TNF agent as well. Now, biologic agents are serious drugs. So TNF, tumor necrosis factor, is a cytokine that has survived evolution, and it survived evolution for a reason. TNF is important in maintenance of the granuloma. And there are reports of serious infections, opportunistic infections such as TB, rare reports of lymphomas. That's probably more the rheumatoid than the disease, than the drug. Reports of demyelination, some hematologic abnormalities. You can get infusion reactions with Remicade, some reports of CHF and drug-induced lupus, and also, paradoxically, you can see drug-induced psoriasis as well. So this is just looking at granulomatous infections, and I appreciate the denominator is different in these. However, even if you factor in that, I think infliximab seems to be, because it's a monoclonal antibody, if you just look at tuberculosis, this is from 2003 when these drugs were first being used, there is significant amount of TB in these patients. Now, if you're seeing patients that come in and they've got weird FUOs and they're on these biologic drugs, think about these other unusual infections. So think of aspergillosis, think of CMV, think of histo. You should be asking them and screening them for histo before you even treat them. Leflunomide is a DMARD. It's more like methotrexate, and you see hardly any of these unusual infections in these patients. I'm going to skip this slide, but this looks at other serious infections across the board and other potential complications with adalimumab, Humira, and other than serious infections, the rest are very low. So these are very safe drugs. They're not perfect. This is from a database in Kaiser, where they looked at these are crude incident rates of TB and not an NTM in patients with general population over 50. These are rheumatoid patients, but this is RA plus anti-TNF, and you can see that the TB incidence definitely increases. So these patients should all be screened for quantiferon gold before the onset of any biologic therapy. I think I'm going to just quickly go through this slide, but this is a really cool slide. Just bear with me. It's a little basic, but this is normal. When antigen is presented to a T cell, you need two receptors. So you need MHC binding to the T cell receptor, and you need CD28 binding to B7. And both of those things have to happen for T cell activation to happen. Once the bacteria or the virus is killed, once the immune system is finished, the T cell actually produces a downregulator. It's called CTLA4, which binds to B7, and it shuts off that process. So you can actually create CTLA4 Ig, which shuts down your T cell response. Now, I'm going to show these next couple of slides just for fun, but and this just shows the complexity of the immune system. So there's a company that actually decided to make a molecule that blocks CD28. And it's really interesting what happened. And this was in 2006, where they actually gave volunteers, they actually gave this to med students, monoclonal antibody against CD28. This was in the UK. And they found that within 72 hours, these healthy volunteers had developed, almost all of them, multi-organ failure. They developed transaminitis. They developed, like a septic lung type of picture. They had bone marrow failure. And So the drugs are, and this, by the way, so if you block B7 with CTLA4, you downregulate the T cell response, and it's completely safe. If you bind to CD28, you get this cytokine storm syndrome. So these drugs are serious drugs. They need to be respected. And it's not something that I think people should be refilling just randomly, because we do see this from time to time. So that's just not meant to scare you, but it also just meant to show you that we have to be careful with the immune system. And just while I'm on that, I do want to just say just a few things in terms of the primary care world. Before we're giving, a lot of patients see primary care and then they see their rheumatology specialist. So these patients should be getting flu shot. If they're immunosuppressed, probably high dose flu shot. If there's any ID people, I'd love to hear what they have to think about that. They should all be getting the Pneumovax, and they should be getting the new Shingrix vaccine as well. And for those on methotrexate, please make sure they've had LFT, CBC and LFTs at least every 2 to 3 months. Now, one of the discussions I have with patients when we put them on biologics, the first thing that patients ask me is, okay, when can I stop the biologic? And I'm like, well, we haven't even begun. I think I got lost. Can you hear me still or no?
Yes, we can still hear you.
Okay. Can you see my slides?
Yeah, present your view. Perfect.
Okay, sorry. I just got something said that the meeting was stopped. Anyway, okay, so one of the questions that I get when I put people on biologics, apart from the expense, which is not insignificant, I mean, a year of Humira or Enbrel is about $30,000 to $40,000 in the US. And the question people say is, well, when can I stop it? And it's a reasonable question because, there are potent immunosuppressive drugs. And this is a study looking at half-dose Enbrel. So if we decrease the dose and we give 25 milligrams, what happens? And these are remission scores. And what you can see is that the remission, if you cut the dose in two, you can actually maintain the same amount of remission as if you're giving full dose. So that's actually the new thinking now, is that I actually do try and taper some patients. There's a nice Japanese study where they took patients with ankylosing spondylitis and they actually stopped the Humira in half the group, and they gave placebo to them. And at the end of 1 year, 40% of the patients on placebo actually stayed in remission. The makers of Humira, AbbVie, were very upset with that study, as you can imagine, because less drug. So I think I'm going to wind up here. So just to summarize, so rheumatoid arthritis, it's a very common disease, affects 1% of the US population. It's a disease that affects the small joints of the hands, wrists, and feet. About 20% of patients can be seronegative. So think of rheumatoid factor negative disease. So if someone comes in and they have what you think is RA, but their rheumatoid factor is negative, get a CCP antibody. That has a high specificity and high sensitivity for the disease. If in doubt, refer the patient. Please take the patient's shoes off. And I know everyone's in a hurry, but squeeze the MTPs. And I know you're doing that for your diabetics. We want to treat aggressively. We want to treat early. Methotrexate is the gold standard for the reasons that I showed you. It's a very safe drug. It's got highly predictable side effects. And if monitored, it can be given very safely. If I had rheumatoid arthritis, I would take methotrexate. Consider anti-TNF drugs or stepping up to triple therapy if the patient has persistent disease. So if you give them methotrexate, you see them back in 3 months, they're still stiff, they're still achy, they're still anemic. We should be getting more aggressive with those patients. And that includes patients, like I showed you, who are in their 60s, who have deformity. They can get worse. And then aim for complete remission. So less than one swollen joint, less than one tender joint. And I'll finish on just a final plug about coronary inflammation, because this is the new hot topic in rheumatoid arthritis. And we're doing some studies here at Sinai looking at PET MRI in rheumatoid arthritis patients. And this is where we really need the help of the primary care docs, because I think rheumatologists do a fairly poor job of screening for coronary risk factors. So we really need your help getting their cholesterol and their blood pressure and their screening under control. and then aim for complete remission in rheumatoid arthritis. So I think I'm going to stop there, Matt, and I'm happy to open up for questions.
Great, thank you so much, and thanks for a really interesting talk. We'll open up to questions from the group. Either you can unmute yourselves or enter them in the chat box. Maybe you could also tell us a little bit about sort of practically here, because we want to be able to refer patients to rheumatologists in the system. I know there are 2 new rheumatologists here. There's a pretty robust e-consult and video consult service. Can you just give us a sense? I assume our numbers are nowhere near 3 months or whatever to get a new appointment. Do you have any sense of what the best way is to approach a patient who needs to see a rheumatologist?
Matt, I think it's a good question, but I think you actually might be shocked at how long your rheumatoids are waiting. It's actually a good audit project for maybe a resident to look at what's the flow through the Union Square practice, like how long it's taking. Actually, within the nation, it's about 3 to 4 months. The way to do this, is not to, obviously, you can do an e-consult or you can put in the referral to rheumatology. But I think if someone is really hot and they're active and they're miserable and they cannot walk and they can't pick up their baby and they got swollen hands, the thing to do, I think, is to email us or pick up the phone. And I think doctors in general, we do a fairly poor job of communicating with each other. So I love it when primary care doc or someone calls me and say, hey, listen, I've got a hot rheumatoid. They can't walk. Can you see them? And I cannot think of a time when I'll say, no, just tell them to take a ticket and they can wait 3 months. The real challenge with the referral system, though, is that the patients that get in are the ones that make the noise. And so the fibromyalgia patients get in like tomorrow, and the rheumatoids get in like 3-4 months down the road. So I think that you have to really be a really good advocate for your patients.
Okay, thanks. There's a question in the chat. I don't know if you can read it or you want me to read it around pre-op clearance. Is cervical imaging required in all cases or just an advanced disease? And what do you do if there's somebody with less severe disease?
Yeah, I think it's a good question. So if you have, definitely everyone with advanced disease should get pre-op clearance. I think, if you're a new early rheumatoid without deformity, it's probably not necessary. So I think you have to use your clinical judgment. But I think if you're seeing deformities or if you're seeing pannus peripherally, you can assume it's in the atlantoaxial joint as well.
Great. What other questions are out there?
Do people feel comfortable about using DMARDs? That was going to be one of my questions. Like if there's a 4-month wait to see a rheumatologist, do people feel comfortable using prednisone and plaquenil in your patients?
Thanks. That's a great question. I would say, on the inpatient side, I think we do use a lot of things like, or we don't necessarily start them without a rheumatologist, but I think that we've become comfortable with Plaquenil and its use, or hydroxychloroquine, Plaquenil in its use through infections, and that it's a medicine that we don't need to stop for almost any reason when people have, come in with acute other issues. I think when you start talking about the anti-TNF agents, methotrexate or steroids, that's where often we need, for people that still are on chronic steroids sometimes, that's where we need really a lot of rheumatologic support on which agents to start or stop, say in infection, particularly bone infections or deep soft tissue infections or an abscess somewhere. That's the trickier part.
Yeah, I agree entirely. That's great. I'm glad that's been the plus of COVID, is that people are comfortable using Plaquenil now. And it's not a bad drug, and you're exactly right. We even use it throughout pregnancy.
Right. All right, any other questions out there? Nothing. All right, Dr. Ali, thank you so much.
Okay.
Always a pleasure to hear from you.
Yeah, thanks for the invite. Take care.